So I'll present on initial pilot results for an ongoing implementation of direct facility financing. Next. So most I'll run through a bit of background and then try to quickly move to the results. So the background to the direct comes from previous failed results-based financing schemes and RBF. I think in one meeting when I said failed, but that's what the evidence tells us. And so, but then an attempt to recover the idea that when you incentivize results, you must kind of improve, or performance-based financing should, in fact, incentivize results. So for the Malawi, so in Malawi, mostly budgets are partially decentralized to district councils. Those of you in PFM probably will know this. So at the district council, the budgets, so from national level, there's kind of decentralization to district councils. But then what happens at district council is that the money is put into a district council account for all the sectors, and then the council spends, procures on behalf of facilities. From the district, there's no layer of decentralization to provide facilities with budgets. So most generally, facilities do not have an allocation, and then as a result, they are not spending the money themselves. And of course, as a consequence also, there's no monitoring of the budgets at facilities. So from previous PFM studies that our team has done together with World Bank and UNICEF, this was noted as a key limitation to linking money to services. So there's a link between the money and the services, or what you actually buy with the money that we have is undermined. And we know that, of course, without decentralization, another complication arises. Decentralization assumes power to the people, at least, but without devolving then we're taking away the component of decentralization that would have gelled the communities around the money and then self-delivery. So in this study, while we try to resuscitate the RBF, PBF designs, mostly we take a PBF type. Our entry point is resuscitating or restructuring the health facility management committees to function to a level of at least some functionality of a board, and then give them ability to oversee the budget planning, execution, and monitoring, which are then the core PFM functions. And then as we do that, we compare the results at baseline, and then, but most limiting at this point to the PFM outcomes of budget planning, PFM processes of budget planning, execution, and monitoring, and then the basic PFM outcomes of to what extent that can facilitate efficiency, quality, accountability, and equity. Next. So from 2019 to 2021, we had developed the master plan for the DFF. But in 2022, government secured funding from FCDO, and then contracted UNICEF to do the implementation. And through the same grant, HEPU shifted to an evaluator. And in 2023, the first pilot was then executed in Rumphi. And most baseline, and then the process results from the Rumphi pilot. Next. Yeah, so in Rumphi, the money mostly was about 1 million to 2 million facility. And the facilities applied the money across to undertake minor infrastructure maintenance and or constructions, minor equipment and supplies, procurement, cleaning and sanitation, office and stationery supplies, general facility improvements, and utility. So all these previously would be, or in the other districts, these would be the activities being facilitated either national level or at a council, or with marginal involvement of the communities. But in this grant, these activities are being undertaken by the community via the DFF grant. So the grant is transmitted as a community grant. It goes directly to the community, is executed by the Center Management Committee, community governance structure. Next. So the main design has 4 arms, excluding the treatment. But in the Rumphi design, what's been activated is the last arm of our design. So the Facility Management Committee currently comprises the facility managers and community governance, community members. Yeah. So there we test the hypothesis that by activating this structure, we can achieve same results or stronger results for PEFA across planning, budget, execution, and evaluation. Next, please. Yeah, so mostly in Rumphi we're testing, so we're collecting data from 15 facilities, and then we've used another survey, the TANSI, to collect baseline data from districts across Malawi to then avoid contamination and allow so initially we had aimed to take HEPU as a control, but there were some complications that arose. The DHO for HEPU was, the director for HEPU was trained in TFF as well without the money. So we tried to, so we had avoided the contamination of the control itself. Yeah, so, and then we use a PFM assessment too, and most mixed methods approach. Next. Yeah, so the PFM2 most raise performance of a facility from D to A. We know D is bad performance, and A obviously good performance. And then across budget formulation, execution, and evaluation. When a facility scores A, it means they're able to plan, they're able to execute, they're able to monitor the budget, and we assess departures from that idea. Yeah. So next. Yeah. So the initial results. So at baseline, we distinguish charm and government for a reason I'll come to. But from the baseline results, we see strong performance for charm hospitals, but similar performance for charm health centers, government and government health centers. So next, yeah, and then in the Rumphi pilot, what we see currently, so in Rumphi there's no hospital in the survey, in the sample. So we mute the hospital comparison. But what we see was that if you compare, so there was no hospital for charm. But if you compare the government hospital performance, performance after the DFF we see a lot of shifting towards good PFM performance across budget formulation, execution and evaluation, and in a direction that can support achievement of efficiency, equity, and quality and accountability goals. We also see marginal shifts at the moment for the government health centers, but I must mention that in this, what we haven't done is to bring the DFF management directly. So when we replace the government health center scores with just the management of the DFF funds, we see similar results to what we see in the hospital. So a major shift in the capacity of the governance structure, community governance structure, to provide oversight. Next. Yeah. So mostly we conclude that with transferring of funds to facilities, we see capacity to manage the funds, and also, more importantly, we don't see evidence of mismanagement at this point. So, which is some important finding. Next. Yeah. So, with a few limitations that I'll jump. Next, please. And then, yeah, so the key recommendations that we make from there is to recommend scaling up of the DFF, but also an important one at the moment is the Health Center Management Committee combines with the facility management, which from an accountability point of view still doesn't resolve. So including our results are then limited in that sense that what we are checking, what we are seeing is a confounded effect of both community capacity building of the management itself and of the governance committee. So, but in the subsequent iterations, we'll then aim to isolate the partial effect of the community governance, and then to be able to conclude that it is a community oversight strengthening that still has an independent effect from the capacity building of the management. Yeah. Yeah. Next. Yeah. So just a bit of evidence that that's what's happening there. Ability to plan, execute, and then they place these things on the notice board. So next. Yeah. Next. Yeah. So just to acknowledge a right team behind this, my colleagues at HEPU as well. Thanks so much.